today's section, I'm actually going to start orthopedics and rheumatology. However, when I was reviewing the last respiratory medicine lecture, I realized that I made an embarrassing error when it comes to CAP 65. So I'll actually just quickly review that, because there is the CAP 65 and then there is the extended CAP 65. And while I learned both, when I was doing my presentation, I mixed up the two and ended up with a mess. So really, I could perhaps just go back and delete the videos, but then it won't be an honest account of how I'm doing. So that's why instead of just deleting the mistakes, I prefer to correct them, after a review. I also have noticed that I keep saying interthoracic muscles, which is wrong as well. It's intercostal muscles. I know it's intercostal muscles, but I have noticed that I've said it more than once. Interthoracic, and obviously that is an issue, and I'm quite embarrassed about it, to be honest. So I'll just quickly do the CAP 65, which really is a scoring system for community acquired pneumonia, and it grades everything. So it's based on out of 5 points. That's points. It gives a single point for every aspect. For example, like confusion, that's new onset. And then there is the urea, that has to be more than 7 millimoles per liter. And then there is the respiratory rate, that is more than 30 per minute. And then the blood pressure can be a systolic of less than 90, so S, which is less than 90 millimeters per mercury, or a diastolic that's less than 60 millimeters per mercury, and they have to be over 65 in terms of age. So everything is graded 1, for everything, for every yes you give 1 point, 1 point, 1 point, 1 point, and 1 point. So it's up to 5. And then if a patient scores 0 to 1, they can be treated at home as an outpatient, but obviously closely followed up. Home, but closely monitored for any, depreciation, including things like sepsis or respiratory failure, things that really are red flags for coming into hospital and being admitted, and probably admitted into ICU. So they have to be closely monitored. If they score 2 to 3, they can be treated as an inpatient. They have to be treated as an inpatient, and this is a short stay in hospital and possibly in a medical ward. And between anything more than, between 4 and 5, they have to go into ICU because they're quite severe. So this is the basic scoring system for community-acquired pneumonia, and it is based really on mortality, on trying to identify the patients who are at risk of dying. And the risk, for example, is people in this category have a low risk of dying. I think it's about 7%. Whereas if you get to people between 4 and 5, their risk is augmented to something like 57% risk of dying. So it's more than half of patients who score between 4 and 5 are at a risk of dying, really. And then the extended CAP 65 will grade exactly the same, but then it then adds 3 points. So okay, so 3 points. So it ends up being a total of 8. And the 3 that are added are a lactate dehydrogenase, which is LDH, and that has to be more than 230 per liter. And then there is lactate dehydrogenase really measures tissue damage, and the tissue damage that occurs is due to hypoxia, and obviously, as we know, hypoxia is part of respiratory failure, resp failure type 1. So really that's what it measures, because it just means that someone is undergoing anaerobic respiration, which is why they have a lot of tissue damage, and they are hypoxic, and indeed in respiratory failure type 1. LDH is an enzyme that's found in a lot of tissues, including the kidneys, the liver, the part of the GI system. So really the enzyme measures tissue damage, which means that the body is using is breaking down tissue for energy due to being hypoxic. The other aspect measured is platelet count. That is less than, platelet count that is less than 100. And then we also measure, what else do you measure? I've forgotten actually. LDH, platelet count, and anyway, I'm sure it will come to me. So then the 3 will then add albumin, and it has to be less than 3.5, which is obviously normal. 3.5 being normal, so it has to be less albumin. So because obviously albumin is needed for proteins, and it also measures kidney damage as well, if there's less albumin. So and liver damage as well actually. So all of these will then get 1, 1, 1, and end up being up to 8, and then the criteria then changes from being between 1 to 2 is low risk of death, and then between 3 to 4 is intermediate risk of death, and then anything above 5 is high risk of death. And again, the treatment can be treated at home as an outpatient, but again closely followed up. Intermediate will require short stay in the hospital, and high risk will have to go into ICU. However, the extended CAP 65 also requires that if someone is deemed to be or is graded as low risk, they also have to satisfy other criteria, such as they have to be less than 50 years old, and they have to have normal SATs and normal body temperature, normal, everything has to be normal, basically normal temperature. Obviously temperature will be raised a bit, but it cannot be more than 40 degrees Celsius. And they have to have and they have to be really, you know, well enough to go home. But again, the well enough based on the clinical picture also has to be graded further based on their age, and not having cancers or any other serious long-term diseases, and not also having new onset of confusion, because even if they are said to be low risk based on the extended CAP 65, if they have new onset confusion, then that changes from being low risk to requiring treatment as an inpatient. And another thing which I actually forgot is the complications that it's sepsis, and again the indication for ICU is sepsis, and sepsis can also be graded as just severe sepsis or sepsis that requires treatment with vasopressin. So I think that's all that I wanted to say in terms of CAP 65, and including the extended CAP 65. I am quite embarrassed that, you know, I messed it up so much in the last section by not differentiating properly and sort of trying to focus on just CAP 65. And then really, I just want to clarify that the muscles that run in between ribs, or this being the mammibrum, this body of the sternum in the xyloid process, and the ribs, the muscles that run in there are called the intercostal muscles, and they are the part of the respiratory muscles that we use for breathing. And obviously these will also include the scalene, the diaphragm, and the abdominal muscles in terms of labored breathing, and also of course the sternocleidomastoid. So they are called intercostal muscles, and they are not called interthoracic. I mean, there is the anterior thoracic muscle. I don't know why I kept saying that, but anyway. And the artery and vein is the subclavian. There's a time when I think I've been saying clavicular vein and artery, but it's the subclavian artery, and they lie on top of the first rib under the clavicle, which is why they're called the subclavian. And obviously any clavicular traumas will, there's a high risk of a massive hemorrhage due to the damage of the arteries and veins, the subclavian arteries and veins, due to their position on the first rib. So now that I've corrected that, I feel a bit better, and I'm not as embarrassed as I have been feeling. So I'm not going to just introduction to orthopedics and rheumatology. So in this first section, really, I'm just going to look at the bones of the upper limb. And the reason why I've started with the upper limb is because I've obviously just been focusing on the thorax, and it just makes a lot of sense to move from the thoracic cage and then focus on the upper limb and then descend inferiorly, into the lower limb, including the vertebral bones of the axial skeleton. So in terms of the bones of the upper limb, they include 4 parts, which are the scapula. Actually, I won't say it like that. They include the 4 regions. Shall I say 4 regions? of upper limb include the shoulder, the arm, the forearm, and the hand. The shoulder is made of the scapula, the clavicle. It's called the pectoral girdle. And the joints, the glenohumeral joint. The arm starts at the glenohumeral joint, and it really has the humerus, which is the longest bone of the upper limb. The forearm is made up of, it starts at the elbow joint and extends into the radius. So humerus 2, elbow joint, and then the forearm will start at the elbow joint and extend into radius and ulna up to the wrist joint, and then we'll have the hand, which has the metacarpals, the carpals, and the phalanges. So the hand obviously is important because it has a lot of nerves, and we use the hand for, sensing, touching, for feeling, and including temperature sensing. So it has a lot of nerves. So today I'll just really focus on the shoulder region up to the proximal humerus, and then on the next section I'll then focus on the shaft of the humerus extending into the hand, and indeed then do all the muscles, and then complete all of the anatomy with a view of then doing pathologies. But then today I'm just going to quickly do a very brief introduction of the bones, just the shoulder up to the proximal humerus. And for this section, because it's anatomy, it's easier to use a model, and I have my model with me. So I'll leave my model on the chair there, so that you can be seeing the camera. So I'll just start anteriorly. Should have prepared better. I am the one who has actually amputated some of his limbs for my own personal study when I'm studying. It's so much easier to... Okay, I'll leave his hair to flop if it wants to. I have no idea why it's doing that today. I'll leave his head like that. But I am the one who has amputated some of his limbs. For example, here is his arm, which belongs there, and his knee is by the windowsill over there. His lower limb, the left lower limb is by the windowsill over there. So in terms of the upper limb, it's made up of the clavicle, the scapula, the humerus, the radius and ulna, and the hand. So today I'll just focus on the uppermost aspects, the uppermost aspects. So I'll start off with the clavicle, which really I have discussed a lot during cardiology and respiratory medicine. So the clavicle is an S-shaped bone. In terms of saying S-shaped, we mean an S that's lying on a horizontal, as you can see there, and it has calves which allow for articulations with muscles and ligaments and also bones, and also allow for spaces. For example, the subclavicular muscle lies just under there, under that curvature that's formed there. And for example, again, the acromion process is allowed to, did I say the acromion? The coracoid process, again, lies just under the clavicle there. So its curvatures allow for that. So the clavicle has, I think I'll just write, I don't know what to, the clavicle has two prominent articulations that we can see. As in more medially, it articulates with the manubrium of the sternum. And then more distally, it articulates with the scapula. I mean, laterally, it articulates with this scapula. Medially, it also articulates with the first rib. So, when we look at the clavicle, its articulation there with the sternum is the only articulation really of the whole of the upper limb with the thoracic cage, with the ribs, and indeed with the axial skeleton of the human body. So that means that the upper limb has a lot of range of motion, a lot of flexibility, and it can do a lot of motions such as picking up things, striking, and due to its flexibility, because it hangs on a hinge really from that sternoclavicular joint there, and everything just hangs on, and it's all tethered to the skeleton, to the thoracic skeleton, by a lot of muscles and ligaments. However, the only true articulation with the bones is at the sternoclavicular joint, which is just there. So that's joint which I'm talking about is this one. So we'll call it the sternoclavicular joint. So that is the single joint for the entire upper limb, therefore allowing the upper limb to have a lot of range of motion. And then as we move laterally from the medial aspect, under there we'll have a ligament that is called the costoclavicular ligament. And the costoclavicular ligament allows for allows for an articulation between the first rib and the clavicle, and it keeps that all in place, and forming strengthening that joint there. And underneath we just have a muscle that's called the subclavicular muscle, and that muscle again attaches the clavicle to the first rib. And as we move laterally, there is an articulation there with the scapula. This is the scapula of the human body, and the clavicle has an articulation with the scapula, and that articulation is called the acromioclavicular joint. So from the clavicle we then have a scapula, which it articulates with scapula laterally, and the scapula has well, it's a triangular bone, I would say, triangular shaped bone. We describe it as a triangular shaped bone, and it has a medial border, a lateral border, and a superior border. However, it has angles, a superior angle there, which would be that, and an inferior angle there, and a lateral angle there. So the superior angle, the scapula itself overlays ribs 2 to 7, where the superior angle actually overlays the second rib itself, and the inferior angle overlays rib 7. Then the lateral border of the scapula extends more laterally, and at its most superior aspect, at the superior angle, there is the shoulder joint, which is called the glenohumeral joint, where it articulates with the head of the humerus. And if we were to look at the scapula, if I was to draw it, I mean, it's just that this one is so, mine is so small, my model is so small, but if we were to draw the scapula, it looks like a triangle, triangular shaped almost, and then it has, running from its medial border, there is a division, a bone that divides and runs across the scapula, extending more laterally to terminate at a projection that we call the acromion. And that bone there is called the spine of the scapula. And what it does, it divides the scapula into two regions, a superior region which we call the supraspinatus, and an inferior, well, it's called a fossa really, supraspinous spinous fossa, and an infraspinous fossa. And that projection there is called an acromion. And we see it there, the acromion actually articulates with the lateral border of the clavicle. I haven't drawn the clavicle properly, but the clavicle will be there, articulating with the acromion at the acromioclavicular joint. And the scapula as well has another projection, which this will be the posterior angle, where we can see the spine of the scapula. It lies posteriorly. Anteriorly, it has a projection which extends anteriorly, and that projection is called a coracoid process. It looks like a bent finger. And it really overhangs, and it is an attachment for a lot of muscles, particularly the muscles of the rotator cuff. So the articulation that's formed by the clavicle and the acromion of the scapula actually forms the glenohumeral, or the glenoid fossa really, where the humerus articulates with the scapula and the clavicle. So the fossa that is formed is called the glenoid cavity. It can be called a cavity, in fact. And really, it is the actual shoulder joint, and it is a very shallow cavity. and it is lined inside by the glenohumeral ligament, which actually allows the articulation surface, the acetabulum, to be deeper, because of the glenohumeral ligament, which lines the glenoid cavity. And the point or the usefulness of that ligament is to stop the head of the humerus falling out of the socket, falling out of the cavity, and to stabilize the shoulder joint as well. So it works with the capsule of the shoulder and all the muscles of the rotator cuff, which I'm actually going to discuss. So while we're here at the scapula, looking at its posterior aspect, I will just mention that we have there are muscles that are the intrinsic muscles of the scapula, and at the top there, superior to the spine, there is the supraspinaceous muscle, which forms part of the rotator cuff muscles. And we also have the infraspinaceous muscle, which lies in the infraspinous fossa. So that would be the infraspinaceous muscle lying there. And the other muscles of the rotator cuff, while I'm here, will be the teres minor, which lies at the lateral border of the scapula, just superior to the teres major. So this would be the teres minor, which is part of the rotator cuff muscles. Shall I write it in red to differentiate it from other muscles? So this is teres minor, and teres minor lies with the lateral aspects of the scapula, just superior to teres major, which is not part of the rotator cuff muscle. So while I'm showing where these muscles arise, I will then later on show where they insert at the humerus, and indeed teres major inserts at the shaft of the humerus. On the medial side, the medial border of the scapula, we have, the rhomboids. The rhomboids. Again, the rhomboid major and minor over lying more superiorly, and then at the anterior aspect of the scapula, which actually overlays directly